Good morning, everyone. We're here live at the Miller Amphitheater here at St. Joe's, as well as delighted to welcome everyone who's joined us on Zoom. My name's Dr. Madeline Verhovsek. I'm the Chief of Medicine here at St. Joe's. And I am going to try to advance the slides. There we go. So we'll start with our land acknowledgement. We acknowledge that St. Joseph's Healthcare Hamilton sits on the traditional territories of the Mississaugas and the Haudenosaunee nations and is within the lands protected by the Dish with One Spoon Wampum Agreement. This is a treaty between the Anishinabe, Mississaugas, and Haudenosaunee that bound them to share the territory and to protect the land. Subsequent Indigenous nations and peoples, Europeans, and all newcomers have been invited into this treaty in the spirit of peace, friendship, and respect. And it's my absolute pleasure to welcome Dr. Sheila Laredo here today. She's going to be speaking with us on the topic of polycystic ovary syndrome, why internists should care about reproduction, which is a great title. I'm also delighted to welcome many members of our endocrinology division here in person. And we have our head of service for St. Joe's, Dr. Mira Luthra, here in the audience. We have Dr. Will Harper, the division director, and Dr. Ali Prabtani, who I believe is head of service for HHS, who's head of service for HHS endocrinology. Will, apologies. And beside me, I have Dr. Manuela Braga, who has arranged for our speaker today, and will be providing a further introduction to Dr. Laredo. So welcome, Manuela.
Good morning, everyone, and it's my pleasure to introduce our speaker today, Dr. Sheila Laredo. So Dr. Sheila Laredo is currently Chief of Staff and Active Endocrinologist at Michael Garron Hospital. She holds a PhD in Clinical Epidemiology, and she's an Associate Professor at the University of Toronto Faculty of Medicine. Her clinical interest is in women's reproductive health and the role of insulin resistance and obesity on reproductive health outcomes. She is an enthusiastic teacher, has mentored many trainees, physicians, and leaders, and has been a recipient of several research and teaching awards. So it's my pleasure to introduce her today, and we look forward to your presentation. Thank you.
Thanks very much, Manuela, and thank you for inviting me. It's really nice to see friendly faces, and it's starting to get alarmed at how all the friendly faces are people I've trained rather than people who've trained me. So it is a pleasure. Some of you who are familiar with PCOS will have heard some of this information, but I hope a lot of this information will also be new to you and of interest. I really wanted to, so the objectives are here, to define PCOS in a way that allows you to make the diagnosis in a practical way, and recognizing that while the internists here will be treating PCOS, many of you won't, and that's okay. What I really want you to do by the end of this round is to have sort of a 15-second way of being very suspicious that women have PCOS, and on that basis, think about your own subspecialty and the way in which PCOS interacts with your subspecialty, and it interacts with many, and we'll talk about that at the very end. So the first set of, there's really three sections. The first set of slides is talking about PCOS and its diagnosis. The second set is talking about the very complex pathophysiology of PCOS. And if it seems like I don't totally understand it, I don't totally understand it, even after 25 years, but I'm getting there. And I think we, as a population of folks interested, are starting to get there, but there's still a lot to learn. And then finally, I want to talk about the way in which understanding the complex pathophysiology, and in particular the piece about insulin resistance, is really linked to reproduction issues in PCOS, and frankly, reproduction issues in other women, which we'll just briefly touch on. And by knowing that you can then better target the care regardless of your area of expertise. So these are my disclosures. I'm not talking about any of the medications for which I've consulted. So this is not a diagnostic dilemma for you. This is just to give you a flavor of what PCOS looks like. A 32-year-old woman, never pregnant, has a history of regular periods to the best of her recollection, went on a birth control pill in her late teens or early 20s for contraception, and then several years later stopped the birth control pill to conceive, and since then has had irregular periods and has not been able to conceive. And when you do a little bit of further questioning, she does notice that there's been a very gradual 20-pound weight gain. She's otherwise healthy, but there's a bit of family history of type 2 diabetes and her early heart disease. And so, again, this is PCOS. And as we talk through some of the diagnostic issues, you'll see that for those of us who are endocrinologists, this is very likely PCOS, and hopefully by the end it will be for you as well. And so PCOS is the most common endocrine disorder in women of reproductive age, so basically women under about age 45. When I first started talking about PCOS, I said 3 to 8%, and then I said 5 to 10%. Now we say 6 to 12%, and there's a more recent study that estimates it may be as high as 15%. We don't really know why. We think some of it might be due to the increased worldwide prevalence of obesity. But we also know that despite multiple healthcare touch points, the majority of women still remain undiagnosed. And so it's very, very common. And there are 3 different types of criteria for diagnosing PCOS, but the vast majority of people currently use the Eschery-Rotterdam criteria, which were developed in 2003. And it really is, the diagnosis is entirely clinical. So it's having 2 out of 3 of these criteria and excluding other causes. So PCOS is a diagnosis of exclusion after you've excluded other causes. And so the 3 criteria are oligo or anovulation. We don't have a definition around what the onset is, but we'll talk about what oligo or anovulation is. Hyperandrogenism, which is high male hormone effect, and that can be clinical or biochemical or both, and that's still one criterion. And polycystic appearing ovaries on ultrasound, which is really just about ovarian morphology, and there's some criteria that we'll talk about. And then we'll very quickly go over the exclusion of other diagnoses. So, what is normal? And it's really interesting when I train trainees and we talk about normal periods, a lot of trainees don't actually know what normal cycles are. And so it's important to know, because if you don't know what normal is, you can't know what abnormal is. And so normal cycles, although in medical school I got taught 21 to 35 days, that's actually 21 is short. That would not be a normal cycle. And so a much more normal cycle would be somewhere between 25 and 35 days is the current criteria, although I'll show you some data that even cycles beyond 32 days may confer increased risks, and in particular cardiovascular risks. Menstrual flow, again, we got that wrong too. I've always been taught that the maximum normal is 30 milliliters, and it turns out that median menstrual flow is closer to 80 milliliters. Most of us can assess this by sort of asking about the use of feminine hygiene products. The duration should be 3 to 8 days. And while pain is not unusual associated with menses, it is never associated with PCOS. So when you see pain, it is not PCOS. Why? Because PCOS is about having many tiny follicles in the ovary. It's not around large cysts. So if you have a woman who has 2, 3, or 4, or 5 centimeter cysts, even though she has many, and cysts, that's not polycystic ovary syndrome. That's something completely different. So I'm going to refer back to this. This is from the Androgen Excess Society Consensus Statement. It's old, but I like it because back in the days when we were trying to get our hands around what is PCOS, they compiled this data from many studies that were trying to get their hands around what is PCOS. And you'll see that they put the data together and they give us a sense of, for each of the criteria, what's the prevalence. And so the prevalence of oligomenorrhea in women with PCOS is really only about 80%, and the other 20% actually will have regular periods. Interestingly, regular periods isn't always consistent with ovulation. So we know that in women who are hyperandrogenic, they can appear to have regular periods and in fact not be ovulating. So this is one of my favorite slides. Again, really old data. And It comes before we had any criteria for PCOS, and yet they used what turned out to be the NIH strict criteria for PCOS, which is having irregular periods and evidence of hirsutism. And what they did is they looked at women who had irregular periods, and they did ultrasound, they did blood work, they took histories. And what they found is that if you take all women with irregular periods, 3/4 of them have PCOS. And if you exclude women who have anovulation, in other words, no periods, and you only look at women who have infrequent periods, 90% of them will actually have PCOS. And even though this is 1987 data, there is data from the Nurses' Health Study that is later on and then more recent, all confirming the same thing. Women with oligo ovulation, 85 to 90% chance that they have PCOS. And so for those of you who are not endocrinologists or gynecologists, what is the easy question? Do you have irregular periods, right? So to the point of 15 seconds, we just took up 5 of them, I think, asking the question. And by itself, that will open the door for all these things that we're going to talk about related to PCOS. So this is from the Korean Nurses' Health Study, 9,000 nurses that they looked at, and they looked at factors that were associated with menstrual variability. And what they showed is that women who have later onset of menarche more likely to have irregular periods. Interestingly, and this is true in PCOS, as women get older, their periods get more regular. But we know that metabolic syndrome and insulin resistance worsens with age, and yet periods get more regular with age. And so you don't want to rely on current periods as an indicator of whether women may or may not have insulin resistance. It's about the history of irregular periods. And you can go back even to a woman who's 60 or 70 and say, did you have irregular periods when you had periods? And that is a better question than do you currently have irregular periods? Similarly, and not surprisingly, women who exercise vigorously, more likely to have regular periods. Women who do shift work, less likely to have regular periods. So hyperandrogenism, I like this picture because that's what a lot of women think normal is, right? And so this is somebody who's like been plucked and lasered and foundationed and then airbrushed on top of that. And that is not what normal is. So it is normal to have some degree of male pattern hair growth. And so the trick is to really know how to quantitate it. And when it comes to hyperandrogenism, you can have either high androgens, which typically is total testosterone or DHEAS, or you can have hyperandrogenism clinically, which is hirsutism. We use hirsutism the most because it's the easiest to quantitate. Acne and androgenetic alopecia tend to be a bit more qualitative and harder to quantitate. Important, again, to know that when you see a woman with hirsutism, 50% of them have PCOS. And when you see women who have PCOS, back to the Androgen Excess Society guidelines, which I'll show you, about 58% of women with PCOS have hirsutism. I want to separate out hyperandrogenism from virilization. In all my years, I have never seen virilization in PCOS. So clitoromegaly, lowering of the voice, loss of subcutaneous fat in the female distribution is never, ever, ever PCOS. You should have red flags waving and be looking for other causes. So this is what I just described to you. 58% of women will have hirsutism. And you can see that the majority of women don't necessarily have elevations in total testosterone. And part of that is because testosterone is a terrible assay in women. Not going to really get into that in a lot of detail. This is the Ferriman-Galway score, which was developed in 1960, and 63 years later, it is still the gold standard. It's sensitive, it's specific, it's responsive, and it was built on the basis of really saying, what is the 95th percentile in a general population, and we'll call that the cutoff. And that's what they did in 1960, and it holds up. And so what you do is you take these 9 areas, you score them from 0 to 4 based on the distribution of terminal dark coarse hairs, not the vellus fine hair, and then you add it up, and the 95th percentile is 8 or above. There is some ethnicity-specific differences, and in particular, East Asian women do have less hair, and any hair in the face and abdomen in women of East Asian ethnicity would be considered to be abnormal. So this is just a photograph of what the various scores would look like across the 9 areas. It's really just to give you a flavor of what that might look like, nothing more. And then finally, polycystic ovaries. So on the left, the 2 photos, in fact, the left ovary is the normal ovary. It's the right ovary that is the polycystic ovary. And we know that because the left ovary is showing all kinds of scars, and that's from ovulation, and that's normal. The right ovary has a thickened tunica and is not ovulating, fewer scars. And on the right, what you see is sort of the classic PCO appearance. You don't have to have this, but we call that the string of pearls appearance. It looks like a string of pearls because the follicles are distributed peripherally. These are normal follicles that have failed to progress. So, and we'll come back to that when we talk about pathophysiology, because to some extent, these follicles themselves are preventing ovulation, and we'll come back and talk about that. And so the definition of polycystic ovaries is enlarged ovaries, so more than 10 milliliters, and polyfollicular. So depending on whether you're using an old ultrasound machine or a newer ultrasound machine, at least 12 or at least 25, these are called preantral follicles. They're by definition 9 millimeters or less. And again, only about 3/4 of women who have PCOS will have polycystic ovarian morphology. And conversely, if you take 100 women of reproductive age and do a pelvic ultrasound, 20 to 22% of them will have polycystic ovaries. So polycystic ovaries are not sufficient to make the diagnosis, even though it sounds a lot like the diagnosis, which is PCOS. Okay. So ruling out other medical conditions, we're going to spend more time. We're doing a divisional rounds after this, and we're going to spend a bit more time talking about this because it's a bit more interesting for endocrinologists. But suffice it to say that the blood work that we do in PCOS is not about diagnosing PCOS, it's about excluding everything else. And so by the time you've got those clinical criteria, the rest of this blood work is done to make sure it's not a prolactinoma, it's not hypothalamic amenorrhea, it's not an adrenal or an ovarian tumor. We're not really going to talk about the details of that too much here, but just so that you know, that is why we do this blood work set. When you look at women who appear to have PCOS but have other conditions, in fact, the other conditions are pretty rare. Remember, we talked about 90% of women who have irregular periods having PCOS. Only about 2.5% of women will turn out to have high prolactin, and then really, depending on the population, between 1 and 10% will have non-classic congenital adrenal hyperplasia, tumors, Cushing syndrome, rare. There is an impression that high prolactin is part of PCOS. I'll tell you it isn't. Back in the days when I did my PhD, we measured prolactin in 250 women. 3 of them had high prolactin. 1 we lost to follow-up. The other 2 we found a pituitary tumor. So it's not part of PCOS. So let's now switch over a little bit to talking about the pathophysiology of PCOS. And this, to me, is super interesting, which is about the hypothalamus. The hypothalamus is, it turns out, really inextricably linked. The nutritional status of, and I'm going to talk about women because we're talking about PCOS, but men as well, is inextricably linked with the hypothalamus and the GnRH pulse generator. And it turns out that these metabolic and nutritional signals that hit the hypothalamus actually affect GnRH pulsation. And GnRH pulsation affects clinical phenotype. And so when you've got a woman who has caloric deficit, and you'll be familiar with this, whether it's eating disorder, overexercise, or underweight, the signal to the GnRH pulse generator is to slow down and shut down. And what we see in that situation is that although LH and FSH drop, LH drops disproportionately to FSH, and we'll talk a little bit more about that at the endocrine division. Conversely, PCOS is a condition of plenty. It's an insulin-resistant phenotype. And the metabolic signals, a nice way to think about it is kind of the opposite of hypothalamic amenorrhea. And it's characterized by high GnRH pulsatility, high amplitude, high frequency. And that then tends to have an effect of increasing LH. And so it turns out that actually LH is a really good biomarker of GnRH pulses. And if you start to think about LH that way, it's kind of interesting because we don't have a way of measuring GnRH or GnRH pulsatility. And so the increased pulsatility favors LH over FSH, which is why we often see high LH in women with PCOS, but about half of women will not have high LH in PCOS, and it's very dynamic. So for example, a woman who has recently ovulated, progesterone from the corpus luteum from ovulation slows the GnRH pulse generator, and even within that same woman, during a month when she's not ovulating, the LH is likely higher. During a month when she is, it's likely lower. Insulin and androgens both modulate GnRH neurosecretion. Androgens disrupt the feedback of estrogen and progesterone, which slow down the GnRH pulse generator, and by androgens disrupting that, GnRH is higher. And insulin has direct effects at the hypothalamus, pituitary, and ovary, and if we have time, we'll talk about those as well. So although I've started with the GnRH pulse generator because I think it's super cool how nutrition and reproduction are linked, it turns out that PCOS is much more than that. So many of you will know by now that PCOS is an insulin-resistant condition, and we'll talk a little bit about that. But there's also genetic predisposition. We'll talk a little bit about that. There's abnormalities in steroidogenesis, and in particular androgen steroidogenesis. And then there's environment. And I sort of hinted at it with the case that you saw. Some women who are predisposed to PCOS, amongst women who have PCOS, about 2/3 to 3/4 will always have had irregular periods. And the remaining women, about 1/3 of them, will develop irregular periods typically in response to weight gain. So insulin resistance is selective, and this is true in PCOS and in other conditions too, but it's really important to think about it this way because the metabolic pathways that are responsible for glucose uptake, those ones are resistant. And so what a normal pancreas will do is it will produce more insulin, and you get compensatory hyperinsulinemia, and as long as things are working well, you don't have diabetes and you just get high insulin. But the mitogenic pathways, the growth pathways, the ones that involve IGF-1 and a number of other things continue to be insulin sensitive. And so exposed to hyperinsulinemia, there are tissue-specific effects. And I like to say that a tissue can only do what a tissue can do. So a kidney, for example, will respond to hyperinsulinemia by retaining sodium. A skin cell will respond by producing more melanin and depositing it, and also by growing. And so you can see here that this is an example of Acanthosis Nigricans, which is definitionally a sign of insulin resistance. And those skin tags, which we as endocrinologists think about as related to acromegaly, are actually just related to IGF-1. In acromegaly, growth hormone increases IGF-1, but in insulin resistance from PCOS, that increases IGF-1 too. So insulin resistance directly and with IGH-1 synergize to increase androgen production. Insulin has effects at the GnRH pulse generator. It makes the pituitary more sensitive to LH. And when you have high LH, which we just talked about, that stimulates preferentially theca cells in the ovary, and the theca cells respond by doing what they can do, which is to produce androgens. Also, insulin acts directly at the liver to reduce sex hormone binding globulin, and therefore, even in the context of not elevated androgen, you have elevated free androgen. And it turns out that you may have a lot of patients who say, well, do I have insulin resistance? Can you measure my insulin? Insulin is actually not a great measure of insulin resistance in PCOS, but sex hormone binding globulin is, although it's not covered by OHIP. So I'm going to go sideways a little bit here, and you'll see after this slide why. This is to show you that there are different PCOS phenotypes based on the Rotterdam criteria, right? So you can have 3 out of 3 criteria, or you can have 2 out of 3 criteria 3 different ways. So there's 4 different PCOS phenotypes. And it turns out that when you look at there's only one phenotype that is not hyperandrogenic, and that is the only one that is not associated with metabolic syndrome. Women who do not have hyperandrogenism do still have a little bit of insulin resistance, but it is, in comparison to the women who are hyperandrogenic, they have much less insulin resistance. And it is not androgens that increase insulin resistance. They're just a marker of insulin resistance. And back in the 2000s, there were lots of studies trying to reduce androgen levels and see if insulin resistance would improve, and it would not. Conversely, if you improve insulin resistance, you reduce hyperandrogenism. And so when, again, another 5-second thing, right? You look at a woman, you see evidence of either hirsutism, androgenetic alopecia, which doesn't require any special physical exam, right? You can see it. Or adult acne, which is typically acne that is not premenstrual, that is not in the nasolabial folds, and that is throughout the cycle. Any of those things suggest to you that this woman has hyperandrogenism. As a non-endocrinologist, that triggers you to think this woman has insulin resistance. And it turns out that if you look at women who have just isolated hyperandrogenism, whether it's hirsutism or alopecia, even if you cannot get a diagnosis of PCOS, they are also insulin resistant. They're less insulin resistant than women with a full-blown PCOS, but they're more insulin resistant than women who have none of the PCOS criteria. So back in my day, which was another century, there was a lot of infighting amongst researchers about whether PCOS was primarily about the hypothalamus pituitary or primarily about the ovary and insulin resistance. And I've started to hint to you that, like many things, it turns out that they were fighting over nothing, because it's probably a little bit of both. And so this is kind of a neat study where what they did is they did a cluster analysis where you enter all this demographic data and biochemical data, and you get the computer to cluster women, and the computer clustered women into what they called a reproductive phenotype and a metabolic phenotype. They did a validation set, and these phenotypes held up, and then they did a genome-wide association study looking at interesting genetic variations. And the ones that came up are the ones that I've listed on the right side of the screen. And what's interesting is that women who have a reproductive phenotype tend to have variants in different areas. So in the FSH or LH receptor, in sex hormone binding globulin, and women who have the metabolic phenotype are more likely to have interesting genetic variants in the area of the gene for insulin, BMI, and glucose. So it kind of suggests that there has to be genetic predisposition of both reproductive and metabolic, and that in different women, it will be slightly different balance. So in this study, about a quarter of the women were reproductive and 3/4 were metabolic. And one of the interesting things is that there's this gene called DEN-D1A, which is showing up as being very strongly associated with PCOS. Very early days, but there are some people who think this might be a super interesting gene in PCOS. And it regulates ovarian androgen synthesis by affecting androgen trafficking. And so these subtypes of PCOS appear to be genetically distinct, and clinically you can get a hint of it, right? Because I've shown you that the metabolic syndrome does delineate along the lines. This study found that there was another locus at the AMH receptor that was associated with a reproductive phenotype. And I don't know how many of the non-endocrinologists in the room are familiar with AMH, anti-Müllerian hormone. You may remember it from the developmental physiology days in medical school as being the hormone that's responsible for inhibiting development of the Müllerian tract in male fetuses. However, it is produced solely in granulosa cells in the ovary in women postnatally. And we have used it in endocrinology because it's produced in granulosa cells. It actually turns out to be a nice marker of ovarian reserve. However, that's not its only function. It turns out that AMH also is produced primarily, remember I showed you that ultrasound picture of the little follicles? It's produced in those little follicles. As the follicles enlarge, it's produced less and less. And it's interesting because its main function is actually to keep the pool of follicles that are resting in the ovary resting, so that you don't recruit all of them. And as it drops during the course of a normal cycle, FSH is able to trigger a dominant follicle to ovulate. And typically that's related to having low androgen in the milieu, and AMH increases androgen in the milieu. So although we think of AMH as a good thing because, hey, you've got great ovarian reserve, in women with PCOS, it turns out that not only do they have high AMH in general because they have a larger follicle pool, and by the way, they do seem to have later menopause, which is interesting, but also they produce more AMH per follicle. And so number one, it may fool you on the ovarian reserve, and number two, it may have some deleterious effects in terms of the effect on the ability to ovulate. And so putting this all together, you've got the effect of the hypothalamus that is affecting GnRH pulse generation. That increases LH. LH plus insulin effects at the pituitary increase androgens. Androgens prevent the selection of a dominant follicle. Those small follicles that continue to be present in PCOS produce more AMH. AMH affects the ability of follicles to respond to FSH, and you get anovulation. In the absence of ovulation, I mentioned, there is no progesterone, and therefore you don't get the ability to slow the GnRH pulse generator. And interestingly, there is some data that if you give progesterone, typically in a birth control pill, that some women, by slowing the GnRH pulse generator, you take the birth control pill away, will actually be more likely to ovulate in a subsequent cycle. And some women will actually have noticed that on their own. Sometimes we notice that when we give progesterone withdrawal just to protect women's endometrium. And support for the hypothesis around AMH is that back in the 80s and 90s, we used to do ovarian wedge resections where you took out a little piece of ovary or you drilled into the ovary to reduce ovarian volume. And that actually is, believe it or not, still in 2023, considered second line for treating PCOS, particularly in women who don't have access to fertility clinics, because it does effectively improve ovulatory status. It will not affect insulin resistance because, as you know, insulin resistance is system-wide. It's not located in the ovary. So putting it all together, we can come back to this slide and say, yep, we've talked about some of the how the neuroendocrine effects interact with genetic effects, with what the ovary can do and will do, with abnormal androgen steroidogenesis and with metabolism. What we haven't talked about is environment, and we will come to that a little bit in treatment, but suffice it to say that we know that lifestyle is a very insulin sensitizing diet, and weight loss in particular, and exercise, even in the absence of weight loss, are both insulin sensitizing. And there is very consistent data showing that women who lose 5 to 10% of their weight, which is very similar to what we see, for example, in the Diabetes Prevention Program study around the prevention of diabetes, that these women are much more likely to ovulate. Okay, so let's move on from the pathophysiology into a bit more clinical. So things that you might already know, and we're going to walk through a little bit about these, is that PCOS is associated with high incidence of type 2 diabetes, dyslipidemia, hypertension, and heart disease, and that there are lifestyle benefits. So this is an old study looking at 250 women who came through a gynae practice, and Rick LeGros gave them all glucose tolerance tests and showed that if you look at women with PCOS, 31% of women with PCOS have impaired glucose tolerance, 7 to 8% have type 2 diabetes, for a combined prevalence of dysglycemia of just under 40%. So it really, you'd have to have a good reason not to test women with this kind of prevalence for diabetes. Interestingly, women with normal BMI only have about a 1.3-fold increased risk compared to a 3 to 4-fold increased risk compared to general populations. Because the glucose tolerance is more sensitive in women with PCOS, even though the Diabetes Canada guidelines say you may use a GTT in PCOS, really you ought to do a GTT in PCOS. And so the relative risk does, there have been lots of studies now looking at this, and the relative risk does vary a little bit across the globe, really depending on predisposition to insulin resistance and obesity prevalences in different areas, but still 3 to 5-fold increased risk across the globe of diabetes in these women. And so this is data from the Nurses' Health Study, and this is the older data, and I'm going to show you the follow-up data. Remember that we're looking at women who were working as nurses, right? So these were young women, and even in young women, what they did is they asked them, what are your periods like? Are they regular, usually irregular, or very irregular? And even amongst women who said, and that's like they didn't ask them to define what it was, women with very irregular periods had a 1.5 to 1.8-fold increased risk in heart disease and fatal heart disease, recognizing, of course, that the absolute risk will be low because these are young women. However, they followed these women and did a follow-up both in 2019 and again in last year, and now these women are older, and really this data holds up. And the data holds up both for women who self-identify as having very irregular periods, and also for women who have cycles that are over 40 days in duration. So the intermenstrual interval is more than 40 days. And so that risk is somewhere between, depending on how young the women were when they started, between 15 and 40% higher. So for my cardiology friends out there, when you see a woman and you're wondering if you ask her about irregular periods, this is a cardiovascular risk factor. Okay, so this shows you really just cardiovascular risk by cycle length and regularity, and it really is just showing you what I just said, which is that women who identify as having very irregular periods, or women who identify as having periods more than 40 days apart, have a much higher risk of cardiovascular disease, and this is very statistically significant. And this is just another nice way of looking at that risk. The top slide is about how women self-identify their cycles, and the bottom one is about the intermenstrual interval. So again, around the 40-day period is where things start to go awry. Also, change in cycles is associated with cardiovascular risk. So remember, we talked about women, about a third of women will actually go from having normal to abnormal cycles related to weight gain. Those women who develop irregular periods and also have an increased risk of cardiovascular disease. So things you might not know about PCOS is health-related quality of life is so important. And I can't tell you how much of my time I spend on mental health. Women with a high BMI are stigmatized. Women with hyperandrogenism are stigmatized. But also, there is some evidence that in people who have depression, there is underlying insulin resistance. And we know that that people who have diabetes have a higher risk of depression. We've always assumed that that's because having diabetes isn't awesome. But it turns out that the reverse is true as well, which is that people who have depression are more likely to develop future diabetes later. And so there seems to be sort of this common pathway underneath them of insulin resistance and inflammation. And so it won't surprise you that in addition to the effects of having hyperandrogenism, high BMI, and possibly infertility, that these women suffer with depression and anxiety. And also there's some data around social phobia. And the relative risk is in the range of threefold. Although the risk is more common in women who are obese, it also exists in women who are not. And again, this is a more recent study, just reproducing the same information, slightly different odds ratios, but still high, right? Between 3.8 and 5-fold for depression and anxiety. And again, associated with BMI, insulin resistance, and hyperandrogenism, which is really just insulin resistance too. Disordered eating, also bidirectional. So we don't know which causes which, but we know that women who have PCOS are more likely to have disordered eating, and in particular bulimia nervosa, but also that women who have disordered eating are more likely to have PCOS. And so we don't know causality, but this is a more recent study looking at women coming through a gynecologic practice, and they compared women, controls, just women coming in for routine gynae care, to women with PCOS, and they did an eating disorder questionnaire, a night eating questionnaire, the HADS depression score, and the PCOS-Q, which is a validated quality of life score specific to women with PCOS. And what they showed was that disordered eating was much more common in women with PCOS, and that it correlated with BMI and with depression. Obstructive sleep apnea. So this is one of the first couple of studies that showed that women with PCOS have a 30-fold relative risk for sleep apnea. And so in this study, what's interesting is that the absolute risk for young women was about 0.6%, and then for women with PCOS, it was 17%, so about 1 in 6. So you're talking about women who are presenting with difficulty with losing weight, who have insulin resistance, who also aren't sleeping well. And we know that fatigue further increases cortisol, further increases drive to eat, and further increases insulin resistance. What's interesting is a subsequent meta-analysis has really not only validated what the Vagonsa study originally showed, but also said, yes, but your absolute prevalence risk was wrong, because they started with it appears to be they started with a lower risk group, because the actual prevalence of sleep apnea in general populations of women is closer to 3%. And it turns out if you look across these studies, the prevalence of sleep apnea is closer to over 30% in women with PCOS. So now we're talking about 1 in 3 women with PCOS. How can we not screen these women for sleep apnea? And I understand I still hold the record at Sunnybrook for the patient with the worst desaturation, down to like in the 50% oxygenation at night, which is like Venus gas, right? So these are women who have often very severe sleep apnea. And if you look by year of publication, by country of publication, by sample size, by the type of criteria used for PCOS, the prevalence remains the same. The odds ratio is probably closer to 4-fold, but that's because, as I said, the prevalence in other women is higher than previously thought by the original study, and still the prevalence sits around over 30%. I don't know if you're familiar with the STOP questionnaire. It's validated. It's considered the easiest way to just very quickly screen. I'm not necessarily going to go through it, but if you've got somebody who's saying yes to any of these, the pre-test probability in these women is 30%. And the information I've given you there about positive predictive values is for general populations, not women with this pre-test probability. And so really, to hear that a woman is tired and snoring and has PCOS and that you haven't sent her to a sleep clinic is unfortunate. You can also use the stop bang, which improves the sensitivity a little bit. You can also use a Mallampati score, another 2-second thing, right? Open your mouth, and depending on how much of the pharynx you can see, for each increase in the Mallampati score, the relative risk for sleep apnea goes up about 2.5-fold. All of which is to say, these are multiple little things that you can do in your clinical office as a non-endocrinologist that make you say, this woman has PCOS, this woman has insulin resistance, she has cardiovascular risk, she has metabolic risk. Non-alcoholic fatty liver disease. And I'm sorry, I'm not watching the time, so I don't know where we are. I think we're okay. I'm going to just rush through this. Suffice to say, fatty liver, depending on the study, is somewhere between 5- and 8-fold increased risk in women with PCOS. And what happened there? I don't know what happened. It may be the way the slideshow was set up. I may have to fix it.
You have more slides?
I do have more slides, yeah. So what I was going to say is that even in women who are non-obese with PCOS, that the relative risk of fatty liver is still double. So it's about 5.5% versus about 2% in non-obese women. There's also a risk of endometrial cancer. So women with PCOS, in obstetrics and gynecology, women, the trainees are taught that endometrial cancer is a postmenopausal disease. That is not true in women with PCOS. And if you look at endometrial cancer premenopausally, it is almost entirely women with PCOS. And I was going to show you some data around the fact that women who have endometrial cancer premenopausally have a very high risk of having polycystic ovaries, which is sort of like a marker of PCOS, and high BMI. So when I have a woman with PCOS and high BMI and abnormal bleeding, I go aggressively after looking for endometrial cancer. Thank you.
If you're, yeah, I think it's showing
It's
up
not going
okay
forward,
here.
but it's not moving forward. Yeah. The lifetime risk of endometrial cancer in women with PCOS is about 9%. And so again, and the relative risk is about 3-fold. There's also obstetrical risks in women with PCOS. and I can fly by the seat of my pants. There's also obstetrical risks in women with PCOS, and some of it is BMI related, and if you look at BMI and obstetrical risks, there's all kinds of things. There's actually increased malformation risks, cleft palate, increased risk of dizygotic twins, which is interesting, increased risk of gestational diabetes, pregnancy-induced hypertension, small babies, big babies, early babies, postnatal death. When you look at just PCOS adjusting for BMI, you still have a persistent additional increased risk in gestational diabetes and in pregnancy-induced hypertension. There was one more thing I wanted to say, which I don't remember. So in terms of treatment then, we will talk a little bit more about treatment at the division rounds, but what I want an internist to know is that lifestyle, if you look at, oh, sorry, thank you. Yeah, if you look, thank you. If you look at any of the consensus statements, and there are many on PCOS, that they all say lifestyle first, 5 to 10% weight loss. It won't work for a small percentage of women, right? Because some women always have irregular periods no matter what. And then what you do depends on, I like to call it the my agenda, your agenda, right? So there are things that I must do. So I must make sure you don't have diabetes. I must make sure you don't have high blood pressure. I must screen you for abnormal bleeding to make sure that you're not at risk for endometrial cancer. And I have diagnosed endometrial cancer in women in their 20s and 30s, which is terrible. I also want to screen for mental health, for disordered eating, and for sleep. When it comes to the her agenda approach, some of those things will be covered, but often they also have an interest in treating hyperandrogenism, fertility. Sometimes it's just about weight. And I want you to know that when we come to treating hyperandrogenism, although we call it cosmetic, and OHIP doesn't cover any of those treatments, in fact, there's good data. For example, when you look at laser treatment or treatment with birth control pills to lower hyperandrogenism, that it actually has very significant impacts on depression and quality of life. And finally, for those of you who are comfortable using metformin, there is tons of data, many meta-analyses showing that metformin is great for improving ovulatory frequency. And the reason is that it's an insulin sensitizer. So if you can sensitize metabolic pathways, you can reduce hyperinsulinemia, which means that you can reduce some of the other stuff that's going on that's interfering with cycles. It's not the best treatment when it comes to ovulation induction for pregnancy, but it is an excellent treatment when all you're looking to do is to get more frequent cycles. And by getting more frequent cycles to presumably reduce the risk of endometrial cancer. And we know that there's data from the Diabetes Prevention Program studies that for people with dysglycemia, metformin can reduce the risk of developing diabetes, as can lifestyle. So those are the kinds of things that I want you to think about as we're talking about treatment for women with PCOS. And if I can leave you with a few things, I hope you know what I'm going to leave you with, right? Is that if you see a woman with irregular periods, you should be thinking this is PCOS, and your brain should be going down the pathway. If you're a respirologist, think about sleep apnea. If you're a cardiologist, think about cardiovascular risk. If you're a gastroenterologist, think about fatty liver disease, and so on. And that if you see hyperandrogenism, you should also be thinking about insulin resistance. So I think I'm going to leave it there so we leave some time for questions.
Thank you so much. And what I'm going to do here is just make sure that we can...
If people have questions, should they come up there into the mic, Madeline?
We have a...
Oh, you have a...
Yeah, there is a portable mic, which I've just... It turns on quite quickly, so if anybody... Maybe I'll... Manuela, maybe if you want to take the lead on any audience questions. I think because of whatever technical glitch led to your slides on advancing, we're not able to pull down the slideshow
We can't
here.
end the slideshow?
Let's try closing it. We don't want to lose our Zoom audience.
Yes.
Okay, so there we go. We've got a couple of comments and questions in the...
And we should start with that because we're going to be with Sheila all morning.
Okay, great. So I'll read out this first question here, and then we'll see if we have any further questions either in our live audience or that pop up on the Zoom Q&A. First question here is from Dr. Graham Jones. Really enjoyed your presentation. What are the effects of a vegan diet in PCOS?
It's such a good question, and there's been a lot of interest in whether specific diets are good for PCOS, and there's lots of people selling their wares when it comes to PCOS and diets. There have been a couple of randomized trials, in fairness, small, that have looked at comparing not so much vegan, but low carb versus low fat diets in women with PCOS. And when it comes to effects on insulin resistance and effects on ovulation, it doesn't actually seem to make a difference. It seems to be more about the weight loss than about the specific macronutrients. That's probably true in general. So my PhD was in lifestyle, and there's, if you look at randomized trials of diets across the map, whether it's PCOS or not, it seems, if you look at, for example, like a South Beach diet or a very low carb diet or a very high protein diet or a Weight Watchers diet, they're all pretty similar in terms of the amount of weight loss that they'll achieve. And so I don't necessarily think that a vegan diet is necessary. What we know about diets is that women, this is maybe not rocket science, but nonetheless, it's been shown that the more components of a particular diet that you can adhere to, the better your weight loss will be. And so what I tell people is that if you can't live without pasta, then go low fat. And if you can't live without your steak, then go low carb, right? Recognizing that there are better ways to go low fat and low carb than what I just described, which is pasta and steak. But, yeah.
I just had another idea here, since we've got two of the handheld mics.
We have some questions here in the audience.
Yeah, I'm just thinking if you wanted to hold the handheld mic and be out where everybody can see you, but we'll just test the sound.
Can the Zoom folks hear me?
I think it's transmitting here,
Okay.
so let's we'll see. Yes, Susan Ritchie, thank you, Susan. Okay, great. So maybe I'll just take the one more question from the Q&A here, and then Manuela, you've got some questions in the audience. So can you comment about the role of GLP-1 agonists in the management of PCOS?
I love that question because it's one that we're super interested in, and by definition, because I see a lot of women with PCOS and I see a lot of women with high BMI, when I'm using a GLP-1 agonist.
I think you might just need to hold it close to your mouth.
Okay, perfect. Yeah. When I'm using GLP-1 agonists, it tends to be a lot in women with PCOS. And there are, right now, and I did have another look for this talk, there are still no randomized trials with outcomes that are of interest to me, which is ovulation. There are, on clinicaltrials.gov, a couple of randomized trials that are underway. It looks like the primary outcome is weight loss, which I think is kind of a dumb outcome because there's no reason to think that women with PCOS are going to respond differently. And certainly in my clinical practice, they lose weight just like other people lose weight. And I will say anecdotally, and interestingly, I have had women start to have more regular periods. You do have to have a conversation with women when you give them GLP-1 agonists with PCOS, because a lot of women assume their PCOS is a good form of contraception. And number one, it isn't. But number two, if you get more regular periods, you actually have higher risk of becoming pregnant. And we have no safety data on GLP-1 agonists in pregnancy. And so the recommendation is to be off GLP-1 for a couple of months before you get pregnant. So when I'm using GLP-1 agonists, which is frequently, that is the kind of counseling that I go through in addition to the routine side effects kind of counseling. Does that answer the question?
Okay, that's great. We'll see if we get some feedback from the person who asked the question, but I'll check in the chat. In the meantime, maybe we've got another question here or two in the audience from Dr. Luthra. Go ahead, Mira.
Thanks for an excellent overview, Sheila. I was wondering if you can comment on the best way to screen for fatty liver disease, understanding that in early stages, the ALT is often normal. And so do you order ultrasounds in people, fibro scans? What do you recommend to the general, like to the internal medicine group? I know I check ALTs, but often they could be normal, and we're already counseling about the actual treatment, which would be the weight loss and the diet and lifestyle. But is there anything additional that you would recommend?
No, and that's it's a really good point, and that would have showed up on one of my slides is like, what should I do about screening for fatty liver? Because I don't know that it makes sense to order an abdominal ultrasound on every single woman who has PCOS, especially when we know the prevalence is high. We're probably better off assuming that it's the case and treating as if it's the case. But I will say I do screen for ALT, because if the ALT is high, then I know that they've progressed beyond, right, fatty liver disease to steatohepatitis, and I do have women with stage 3 and even a couple with stage 4 cirrhosis, not on the basis of alcohol, strictly on the basis of fatty liver.
Okay, great. We've got a couple more hands up. Maybe if we can move the mic over to, we've got Dr. Peptani and Dr. Gerstein here. Oh, perfect. Sorry, there's one more in the middle here first. Just hold it down, and then when it flashes green.
Okay. Thanks, Dr. Laredo. Just a kind of a more basic question of how do we actually define irregular menses? Because I feel like, based on what I've seen so far, just in the 2 years of endocrine fellowship, I wonder if we're underdiagnosing PCOS based on how a woman describes her menses are. And I just wonder about how you actually go about asking that question and where you draw sort of a cutoff.
It's such a good question, and I would say I get both, right? So I get referrals, irregular periods, and I'll accept the referral, right? And then they come in and they're like, oh, sometimes 28 days and sometimes 32 days, and I just don't know. And I say, well, that's normal. Okay, thanks. And conversely, I have women who will tell me their period is regular because it's pretty predictable every 2 months, right? And so when women tell me that their periods are irregular, I say, what does that mean? And I will often, most women these days do actually have a period tracker. And so I actually get them to give me the last, 4 to 6 months, whatever they might have on hand. And if they haven't done it and I'm not, like somebody who says I haven't had a period in 3 months, it's easy. Somebody who's like, I don't know, I get them to track it and I look at it. And so I'm looking for cycles that are most often 35 days apart. The research studies say less than 6 to 8 periods per year. But the reason they do that is they want to be 100% sure they're picking off PCOS. Typically, less than 10 a year when they are more far apart than you'd expect. Would be consistent with PCOS, as opposed to somebody who skipped her period when she traveled for a month to Europe, skipped her period during final exams, but otherwise has periods every 35 days and had 10 this year. Sorry, every 30 days. And if you see what I'm saying? So I do probe it a little bit.
That's great. Thank you. I think we just have time for one more quick question, and then we can go to kind of some questions live here after we disconnect from the Zoom. So final question to you, Dr. Gerstein.
Great, thanks very much. Just a comment and a question. Probably the best way to screen for NASH is just with a FIB4 score. All you need is an AST, an ALT, and a platelet count, and it's actually pretty good sensitivity and specificity. But it will not detect NAFLD. The best way to screen for NAFLD is look at their weight and their distribution of fat. I mean, I think, but the question is, for many patients, the biggest concern about PCOS is their hirsutism, not their anovulation, not their weight. I'm not aware of any therapies that have ever shown, other than electrolysis, that have ever shown a benefit on hirsutism. Even spironolactone and metformin, it's pretty modest. Am I missing something? I mean, just in terms of that particular outcome.
Yeah. So the way I think about it is a permanent hair reduction and then other treatments. So permanent hair reduction, it's not permanent hair removal, but reduction. There are two things, laser and electrolysis. When it comes to other treatments, there is benefit for Ferriman-Galway score. So a birth control pill will give you a reduction in the Ferriman-Galway score of about 40%, which is not nothing, right? Because if you've got a woman whose Ferriman-Galway is, but it will take a minimum of 6 months. And if you look at the data, 6 months is to start, but you will continue to see ongoing improvement, certainly in the first year, and even between year 1 and 5, there will continue to be a little bit of improvement. If you combine with an anti-androgen, you'll get a little bit of additional benefit. If you use an anti-androgen alone, you get a similar, about 40% improvement. I don't love anti-androgens alone in women who are of reproductive age because it's not safe for pregnancy, but I do it a lot in postmenopausal women.
Excellent. Thank you very, very much, Dr. Laredo. I want to once again give you huge thanks, and thank you as well to our endocrinology group for inviting you, because it's been a delight to have you here, and I know you're spending some more time with them later this morning. For everyone who's gathered here as well as on Zoom, just a reminder that rounds will be back again next week, June 1st. HHS will be the host in its chief medical resident rounds. And then on June 8th, St. Joe's again will be the host, and we'll be doing a special rounds on key topics in race and ethnicity data collection in healthcare. So hoping that you can all join back with us next week and beyond. Take care for everyone on Zoom, and have a great day.